Welcome to today's case discussion. This is a case of an elderly woman with a mass in the left side of the abdomen. Okay, the patient is a 54-year-old female patient who is a retired factory worker. She complains of a swelling on the left side of the abdomen for the past 1 year. She was relatively well until a year ago when she first noticed a swelling to the left of the umbilicus. She did not seek medical care immediately since the swelling was very small, about 2 centimeters in size at that time, and did not bother her. She noticed that the swelling was gradually increasing in size, and she started to feel unwell 1 month ago when she got bloating and distension of the abdomen after her meals. The swelling also increased in size, but was localized and in about 6 centimeters in centimeter. The swelling disappears when she lies down, and it became prominent when she coughed or lifted something heavy. She did not have fever, nausea, vomiting, abdominal pain, altered bowel habits, loss of appetite, weight loss, urinary retention, headache, or dizziness. She gives a history of 3 caesarean sections in 1991, 1994, and 1993 due to slow progress of labor, and a tubal ligation was also done during the 3rd caesarean section. The patient was diagnosed with uterine fibroids in 2008 and she underwent laparoscopic surgery at HSA, and there were no complications. In 2014, she was diagnosed as ovarian cyst and a laparoscopic surgery was also done in HSA. She recovered from both operations without any complications. She has no history of any medical illness, diabetes, hypertension, or others. Now, based with these symptoms, we will come to the analysis of these symptoms. Okay, she's a 54-year-old woman, swelling on the left side of the abdomen for a year, bloating and distension of the abdomen for the past 1 year, for past 1 month. Swelling also increased in size. It disappears when she lies down, and is prominent when she coughed or lifted something heavy. A history of 3 caesarean sections and 2 laparoscopic operations. Okay, so from these features or symptoms, we have a clinical problem of a 54-year-old female with multiple laparotomies complaining of a progressive swelling lump over the left side of the abdomen for the past 1 year with bloating and distension. Okay, with this clinical presentation, the possible cause will be adhesion colic due to previous surgery, incisional hernia, pancreatic cyst or tumor, gastric tumor, colon cancer, or abdominal aortic aneurysm. These last 4 are based on the location of the lump in the abdomen. Now let's come to the questions which we should entertain yourself on the history. First question, highlight the significant points in the history. Okay, these are the significant points in your history. 54-year-old woman, swelling on the left side of the abdomen for the past 1 year, progressively increasing, bloating and distension for about a month, decrease in size, swelling disappears when she lies down and becomes more prominent when she coughs or lifted something heavy, past history of 3 caesarean sections and 2 laparoscopic surgery. Question number 2, what is the significance of the repeated LSCS in this patient? The LSCS, the 3 subsequent ones, weakens the abdominal wall muscles to predispose to incisional hernia? Question number 3. What is the most likely cause of the patient's problem based on her history? Answer will be incisional hernia with probable adhesions. Okay. Question number 4. What are the predisposing factors in this patient? The predisposing factors are obesity, possible post-operative wound infection and breakdown, poor technique of surgery, closing the abdominal wall, the use of choice of sutures, chronic illness, and trauma. Next, we come to the examination of this patient. The patient was slightly obese but otherwise comfortable. All quadrants of the abdomen were symmetrical and there were no abnormal signs noted. There was a vertical or midline subumbilical midline scar about 8 centimeters in length. Multiple striae were seen over both the flanks. The abdomen was slightly full and there was a 6 by 6 centimeter mass at the left periumbilical region. Cough impulses was noted over the swelling. On superficial palpation, all quadrants of the abdomen were normal with no masses, no tenderness or guarding. On deep palpation, there was a non-pulsatile, reducible, soft and non-tender swelling at the left periumbilical region. It measured about 6 by 6 centimeters. The mass was partially reducible and slightly tender. There was a palpable gap in the vertical subumbilical midline scar. It measured around 2 by 2 centimeters. The bowel sounds were normal. Now, based on the patient's examination, this will be the analysis of the signs that were important in this patient. Obese, female patient, midline scar, subumbilical, abdomen slightly full, especially on the left side, a 6 by 6 centimeter mass at the left periumbilical area with positive coughing pulse. There's no pulsatile, it was not pulsatile, it was reducible, soft, non-tender, and partially reducible. The gap in the rectus muscle was noted. So the clinical problem in this patient is a 54-year-old female patient with a past history of multiple laparotomies, now presenting with a 1-year history of a reducible mass over the left periumbilical region and a gap or defect in the rectus sheath over the midline scar. So basing on this clinical problem, the possible diagnosis will be an incisional hernia due to the previous surgeries, adhesion colic, and possible subacute bowel obstruction, and a pancreatic cyst or tumor based on its location in the abdomen. Now, what are the questions that can be entertained on the patient with from the examination? First question, what are the significant signs in the patient? As I listed before, these are the significant signs. Midline surgical scar, slightly full abdomen, 6 by 6 mass in the left periumbilical region, with positive coughing pulse, non-pulsatile but reducible, soft and non-tender. There was a gap palpable in the scar. Question number 2, what is the palpable gap in the midline scar and what is the cause? It is a defect in the rectus sheath and is possibly due to wound breakdown after her surgery during one of the surgeries that was done before. Question number 3, what is the definitive treatment for this patient? Surgical repair will be the definitive treatment for this patient, which is using a direct repair of the hernia, at the direct hernia, direct position of the edges, or such as the keel or Mayo operation, or the use of a hernioplasty using a mesh, which can be done in the open or laparoscopically. In addition to these conservative measures, such as to reduce weight, muscle strengthening exercises of the abdominal wall, and a supportive belt may be helpful in the patient to prevent recurrence after this operation. Now we come to the differential diagnosis of a mass in the left abdomen, left of the umbilicus, as Chin is discussed here. Okay, this is the patient with the mass in the left periumbilical region. It measures about 6 centimeters by 6 centimeters. It's smooth, the skin, no changes over it, and there's a vertical midline scar, okay, crossing over it. Okay, so it was soft, partially reducible, and non-tender. So these are the possible diagnoses from this patient: incisional hernia, abdominal aortic aneurysm, but this is not pulsatile, pancreatic cyst or tumor because of its location in the area of the pancreas. It could be a colonic tumor as well, or a mesenteric cyst. Okay, a mesenteric cyst that can be located in this region.
Okay, next, what imaging investigations will you ask for in such a patient? First, the most commonly done investigations will be abdominal X-ray, ultrasound scan, and CT scan. These investigations are not routinely done when the diagnosis is clear. In cases of doubt, then you proceed with these investigations. AXR is only done when you suspect intestinal obstruction. Ultrasound and CT scan can determine give you a clear picture of the herniation of the small intestine. Between the two, CT scan is more accurate. And if necessary, endoscopy such as OGDS and colonoscopy could be done. And there is a role of barium enema in these patients, barium meal in these patients, to outline the narrowing or the passage of the large small intestine. Next is question number 3. The following is an ultrasound image of a woman with a large paraumbilical swelling. What is your diagnosis? The answer is ventral incisional hernia. Okay, this is a hernia here, ventral hernia. Okay, there's a defect in the rectus, and the intestine from the abdominal cavity herniates to occupy the space in the subcutaneous area. So this is a ventral incisional hernia.
Name the complications. 4A, name the complications of this condition. Complications include these: adhesion colic, intestinal obstruction, strangulation, and its complications such as gangrene, perforation of the bowel, and peritonitis with septicemia. Question 4B, what are the clinical signs that will suggest the onset of these complications? Pain is a very common symptom. All the while the patient has no pain, now she develops pain, so it's suggestive of complications. Abdominal distension and vomiting. Others include constipation, tenderness over the area of the swelling and the abdomen, increased bowel sounds, later may be absent, and features of septicemic shock. Now, what are the surgical treatment for this patient? First, direct repair, which I mentioned, which include a keel repair or Mayo's repair, which is a double breasting and overlay of the edges. Then you have your mesh repair or hernioplasty, which can be an overlay hernioplasty or a sublate mesh replacement. Release of adhesions, if there are, which are usually present in these patients, and if there is any signs of gangrene or non-viable bowel, then bowel resection and anastomosis should be undertaken. Okay, these are some of the principles of treatment. The conservative approach, if the neck of the hernia is very wide and shows no signs of increase in size, the patient has no symptoms. So if the hernia belongs to this category, then you just observe the patient. Operative treatment, the indications will be symptomatic hernia, which is showing signs of increasing in size and pain or some complications. A large hernia with a small defect is a very high potential for developing strangulation. So these hernias should also be repaired surgically. Okay, this is the diagram to show the repair. This is the rectus. Okay, the right and the left rectus, and a mesh is placed between. Okay, so the site is strengthened, unchanged. The side of the unchanged side strengthened, unchanged. Adynamic central zone, and the circumferential pull by the abdominal wall tightens the mesh. Okay, and increases its strength. Other surgery include the Mayo's operation and the mesh repair. These are the two. This is the Mayo's operation, where the edges of the hernia are brought together with sutures, and this is a mesh. Okay, so for wide neck, small hernia, no or minimal symptoms, don't have to do anything. Patients with a large hernia, narrow neck, increasing signs, or signs of obstruction strangulation, surgery as soon as possible. Okay, again, these are some pictures to show you an incisional hernia here. There's a scar here. Okay, there's herniation into the subcutaneous tissue here, the gap in the rectus sheath. Okay, this is the patient we showed you just now, and this is another case of incisional hernia. You can see a incision here. Okay, this is a mesh repair and a sublay or repair, which is this is not rectus mesh here, overlay mesh, underlay mesh. Okay. Okay, this is the hernia, which is reduced, and the rectus repaired with the mesh placed between the subcutaneous tissue and the abdominal cavity. Now, what advice will you give this patient after surgical repair, or for that matter, any patient after surgical repair of incisional hernia? The nutritional support, a well-balanced diet for proper wound healing to prevent further recurrences, early mobilization after the operation to prevent complications, abdominal support, the use of a hernia belt so that to reduce the chance of recurrence in the post-operative period. In fact, this can be used as a long-term measure as well to prevent recurrences. Avoid lifting weights, and obese patient, as this patient we saw, reduce the weight if possible. Okay, weight reduction, and abdominal wall muscle exercises to strengthening muscle abdominal wall.
Okay, now a short discussion on incisional hernia. Okay, the incisional hernia is the protrusion of the contents of a cavity, usually the abdomen, through a previously made incision in the compartmental wall of this cavity. Okay, in short, it refers to the abdominal hernia at the site of a previous surgical scar. Okay, surgical incision here, so you get a swelling at the site of the scar. It is a type of ventral hernia, and usually the midline incisional hernias are more common than the lateral ones. It's a common complication of abdominal surgery, and its prevalence rate is around 5.2% at 1 year and nearly 25% by 2 years. So the longer it takes, the higher the chance of incidence of incisional hernia. These pictures here show you this is an incisional hernia. This is a scar. The hernia here, the intestine protrudes through the defect in the wall of the abdomen, anterior abdominal wall, and comes out to the subcutaneous space. Here, another picture of an incisional hernia with a scar there. Another one, the scar in the midline, and there is a incisional hernia to the left of the midline on the of the abdomen. Now, what's the pathophysiology of incisional hernias? The layers of the anterior abdominal wall, as shown in this diagram here, this is the midline, the rectus sheath, and the lateral abdominal wall here. Okay, these layers of the anterior abdominal wall are normally very strong and act to maintain the integrity of the abdominal cavity. However, once these layers are interrupted by a surgery or surgical incision or even by trauma, their continuity is disrupted and become structurally weakened. And in the presence of increased intra-abdominal pressure and the potential risk factors such as smoking or obesity, the contents of the abdomen are able to herniate through the weakness in the wall of the abdomen to form an incisional hernia. As with any hernia, complications can occur with incisional hernia, and the usual complications are incarceration or irreducibility, strangulation, vascular compromise, or obstruction, acute intestinal obstruction. Now, what are the risk factors for incisional hernia following an abdominal surgery? Okay, these are the common risk factors. If it is an emergency surgery, then it carries double the risk of elective surgery. BMI more than 25, obese patients are more likely to develop an incisional hernia. Midline incision, the risk is higher, 74% higher than compared to non-midline or lateral abdominal incisions like the hernia. Post-operative wound infection increases the incisional hernia by 70%. Other conditions include diabetes, connective tissue disorders, or the use of steroids. Prolonged use of steroids. These can also cause weakness of the muscle, abdominal wall muscles, leading to incisional hernias. Advancing age and also smoking is another important condition that predisposes to incisional hernia. Okay, what are the clinical features of incisional hernias? Okay, the characteristic clinical feature of an incisional hernia is it is a reducible, soft, and non-tender swelling at or near the site of a previous surgical wound. Okay, very important. You must have a surgical wound. If the hernia is incarcerated, it can be painful, tender, and erythematous. Okay, similar to inguinal hernia. And on examination, you will find a mass palpable at or near the site of this surgical incision, which may be reducible into the abdominal cavity, or in later stages, it may become irreducible. Okay, having said that, you must ensure to check the groins for other hernial orifices, whether they are also involved or not. So in summary, you get a bulge or swelling in the affected area associated with pain. Usually is a dull ache, sometimes severe pain, and this pain becomes worse when coughing, sneezing, or lifting heavy weights. That means there's increased intra-abdominal pressure. And at times where there's adhesions, it can cause bloating or constipation, and then even frank acute intestinal obstruction. Okay, what are the investigations you do? Most of the time, you do not need any investigation. The diagnosis is basically a clinical diagnosis. However, often radiological images can be used to confirm the diagnosis in difficult cases, and this is most often done by using CT scan, and usually is the contrast enhanced CT scan. CT scan imaging can also not only confirm the diagnosis, but in large incisional hernia can help plan the operative management. Then other investigations include abdominal x-rays and ultrasound, serum electrolytes if the patient is having obstruction. Okay, and these are some of the images of, this is an ultrasound image, okay, where it shows a defect in the rectus sheath here, defect here, and the hernia, bowel herniates into the subcutaneous tissue here. Okay, this is a hernia, incisional hernia. And there is a CT scan showing you a herniation here of the bowel, especially in patients who have been given contrast are very easily seen. And here is the hernia. Here is a very obvious hernia, rectus sheath defect, and the hernia herniates into the subcutaneous space around the region of the umbilicus. And laterally, here there's another incisional hernia where you can see herniating to the defect and becoming and goes into the subcutaneous space. Now, what is the management of incisional hernia? Okay, it's conservative. Initially, it's usually conservative in most patients, and also depends if it is small, no symptoms, patient is comfortable. Then what you can do is just treat them conservatively. Yeah, and this conservative treatment consists of wearing of belt or some form of garment over the abdomen to compress the hernia, preventing it from herniating. Then the other factors that must be considered is to reduce all the risk factors the patient may be having. Surgery is required in quite a number of patients when there's failure of the conservative treatment. And surgery consists of the indications for surgery include the patient is symptomatic and who is clinically fit for surgery. The size of the hernia, large hernias tend to be very uncomfortable and may have pain. So this is another indication. An abdominal wall defect size. If the defect size is small, if the neck of the hernia is small, then the chances of strangulation is higher. Then you may want to do a early surgery for these patients. Whereas large abdominal wall defects rarely cause obstruction, and this may be treated conservatively depending on the request of the patient. Then the clinical features, if the patient is having severe pain, I think there's no choice and it hinders the working condition, normal life of the patient, then you have to do surgery. Age of the patient is important. The younger patients, I think you have to do surgery, and older patients may be treated conservatively. Comorbidities, medical conditions, and the patient's preferences as well. Now, what are the types of surgery that can be done, which I already mentioned earlier in the slides? Suture repair and mesh repair. And the third one is abdominal wall reconstruction. As I mentioned just now, suture repair for very small hernias, such as the keel maneuver, direct suturing, or Mayo's procedure. Mesh repair can be laparoscopic and open, and how you place the mesh is another important. It can be an onlay or sublay placement of the mesh. It's either superficial or deep to the rectus. Abdominal wall reconstruction. Large abdominal wall resections are important considerations for some sort of flap to cover the defect in the abdominal wall. Now, having said that, what's the prognosis of incisional hernia? Many patients with incisional hernia remain asymptomatic lifelong, and about 6 to 15% of them will develop complications such as incarceration, and 2% will progress to strangulations. So incarceration and strangulations are indications for surgery. Strangulation for emergency surgery. Okay. So finally, what are the key points you have to take home in incisional hernia? First, the incisional hernia is a hernia that occurs through a previously made incision in the abdominal wall. So it is a post-surgical hernia at the site of incision. Secondly, diagnosis is typically clinical. However, imaging can help to confirm the diagnosis and elucidate the anatomy of the hernia and the abdominal wall. Management is decided on a case-by-case basis. However, if suitable, most patients will warrant surgical intervention.
Okay, thank you for joining me for this short session.